Thank you for joining Cancer Support Community Atlanta for Non-Hodgkin's Lymphoma CAR Tcell Immunotherapy Treatment Updates, facilitated by Dr. Kent Holland with Northside Hospital Cancer Institute Immunotherapy Program and the Blood and Marrow Transplant Group of Georgia, and moderated by Dr. Debra Miller with Suburban Hematology-Oncology Associates. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. If this is your first time participating, we invite you to complete a new attendee form to stay connected to all future programs.
Welcome everyone to today's program, Non-Hodgkin's Lymphoma CAR Tcell Immunotherapy Treatment Update with Dr. Kent Holland and Dr. Debra Miller. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. These include virtual support groups led by licensed mental health professionals, stress reduction classes like yoga and Tai Chi, a monthly nutrition seminar facilitated by an oncology dietitian with Northside Hospital Cancer Institute, and education programs like these. And if you ever miss a live event, you can visit the video tab of our website and find recordings, and you can also find some yoga classes and guided meditation programs there as well. So again, for additional information on how to register or for a complete schedule of events, visit cscatlanta.org. As a reminder, everyone will remain on mute for the duration of today's program. We invite you to enter questions in the program chat box, which Dr. Miller and Dr. Holland will address at the end of the program, time permitting. I'm excited to welcome today's program moderator, Dr. Debra Miller. Dr. Miller received her medical degree at the Bowman Gray School of Medicine at Wake Forest University. After medical school, she completed both her residency and fellowship at Vanderbilt University. She has 21 years of oncology experience and has been with Gwinnett Medical since 2016. She has a true passion for patient care, the community, and inspiring others. So welcome, Dr. Miller, and I will pass it off to you to begin today's presentation.
Thank you, Katie. It's my distinct pleasure and privilege to introduce Dr. Kent Holland. I've known Dr. Holland for about 20 years, and I remember when he began the transplant group with Northside. He is both board certified in oncology and hematology. He is the medical director of the Blood and Marrow Transplant Program at Northside Hospital, co-director of the Northside Hospital Stem Cell Processing Laboratory, and medical director of the Atlanta Blood Services Apheresis Collection Facility. Dr. Holland is also Northside's Hospital Leukemia Program Physician. And then from 2013 to 2021, Dr. Holland was recognized as Atlanta's top doctors in his specialty by Castle Connolly. Thank you. Off to you, Dr. Holland.
Thank you, Dr. Miller. It's very kind of you. I appreciate being asked to give a presentation today. I'm going to talk to everyone today about how we can use our immune system, which is our ability to historically fight infection, how we can use that and manipulate in such a way to actually fight tumors such as lymphoma and leukemias. And this is an area of research that's really been ongoing for 30, 40 years, but it's become quite exciting more recently that we now have the technology to actually begin to program basically like a computer program to change our immune cells in such a way to attack tumors such as lymphoma or leukemia. I'm going to talk a little bit about what's called the innate and adaptive human immune system, and then how this naturally tries to attack what we call foreign invaders, such as COVID-19 infection, for example, is a foreign invader, or cancer, and then how we might be able to genetically engineer our own immune cells to manipulate them in such a way to try to attack a tumor that we want to eliminate. So I think just the important concepts today, we're going to talk about what's called the adoptive cell transfer, which is what CAR T-cell therapy is, but it's based upon all the work that's been done over the last 30, 40 years, understanding better how our immune system works. And essentially, we've evolved over time, over hundreds of thousands of years, to be able to provide protection against invasive pathogens. And we have a variety of immune cells, which we call the white blood cells, as well as what are called antibodies, that are designed to help attack infections primarily, but also can also attack cells in the body that become mutated or changed into, for example, tumor cells. And there's two main branches of this immune system. One's called the innate immune system, and one's the adaptive immune system. And I'm going to be focusing mostly on the adaptive immune system. And this cartoon slide is just giving you an understanding of how we've been designed in terms of our immune cell system, or again, the late term for this is white blood cell system. At the top of the slide, there's what's called the hematopoietic stem cell. I think this is the grandmother cell. Like we have a magic garden. It's a magic seed that can make all the different vegetables, for example, in our garden. And this cell can make what are called the neutrophils and the monocytes and the macrophages and natural killer cells. And these are called innate immune cells. And these are cells that just go out normally looking and scavenging, looking for things that shouldn't be there, like bacteria, for example. And then we have what's called the adaptive immune cells. And these are called the T cells and the B cells. And we have these since we've been born. And every time we're exposed to an invader, such as, for example, the mumps virus, or we get this year's influenza, or we get vaccinated, we create a whole family of these cells. And for the rest of our life, their job is to recognize, to have memory, to remember that we were exposed, for example, to measles or the mumps. And so if we're exposed again to that, they're right there to pretty much kick that invader out so we don't get sick. And that's the whole concept we're currently doing, for example, with COVID infection. We're all getting vaccinated, and that's going to cause our adaptive immune cells to be created such that when we are exposed to COVID, we can quickly eliminate that virus. And the second way that works would be if I, for example, if I was infected with COVID, I got the pneumonia from COVID-19 infection, I would automatically create an adaptive immune cell immunity such that next time I'm much less likely to get sick if I'm re-exposed to that virus infection. So I'm just going to skip a little bit down here to what are called T cells. And T cells are going to be the focus today, but T cells are the immune system cells that activate when we find a foreign invader. And each one of these T cell families can recognize a different invader. So they're very specific. I like to think of them like a key, and there'd only be one. If you and I walked around the hospital, that key would only unlock one door. And that's how specific T cells are. We have thousands and thousands of these families that are designed to recognize an invader and to remember it next time it tries to harm us. So when T cells are activated, they can multiply thousands, if not hundreds of thousands fold to fight their target. And then once it goes away, they then regress and they go back to sort of normal surveillance again. When we get cancer, whether it's lung cancer or breast cancer or lymphoma, for example, our T cells may be able to see the cancer, but frequently cancer cells are very smart and they figure out ways to evade them. Not much different than the old Star Trek series where the Klingons have that invisible shield that they can put over their ships so Dr. Kirk and the Star Trek crew can't see them. And that's what cancer cells try to do. They try to hide from our immune system. So this is just an example of how the T cells develop. And I'm just giving this so you have some background information. So when I talk about the CAR T cells, you'll understand more what we're trying to accomplish. But early on, that mother immune cell I mentioned, the hematopoietic T cell, generates what's called a pre-T cell. And then this goes to a part of our body called the thymus, which is a gland that's in our chest area. And then they circulate around and they get stimulated. And once they're stimulated, they either become what are called effector cells. These are cells that are automatically set up to attack, or they're called memory cells. And that means for the rest of our life, they'll remember that target, that infection, or that disease they were trying to kill. And if they're exposed to it again, they'll be re-recruited. It'd be like having our military on alert, and they've been trained on how to fight. And if the president calls them up to go to war, they're ready to go. And these T cells are activated really two different ways. They can be activated by a cell, for example, that gets infected with a virus, and they create what's called a cytotoxic T cell. And this cartoon on the left just gives an example of how that works. And we have the ability to recognize what's called self versus non-self. And there's a very important molecule on each one of our cells that's just like a uniform. When the Americans back in World War II were fighting the Germans, how did we know who the Germans were? Because they wore a different uniform. And so it's very important that we can identify that our cells can identify our own normal tissue so we don't attack it. And so when the cell's infected, it presents itself and then gives a piece of that, for example, a virus to that T cell, and it recognizes it and then remembers it, and then now is trained to attack it. The second way this can be done is through what's called the macrophages. That's part of our innate immune system. And they're scavenger cells, kind of like garbage trucks that are going around picking up waste. And they bring it to a T cell. And the T cell says, this is going to be important for me to know, and I need to learn about it. And they can process it. And then they also will have the memory to be able to attack when they do see it and come across it. Now, this is a very sophisticated process, and this is just, our body has multiple mechanisms in place to allow this to work correctly, but also to keep it under check so it doesn't go too crazy and make us sick. These T cells are little warriors, and we want to be able to keep them under control. So they first have to be activated, and that's shown here in this cartoon again to the right. They're first activated, and then the mechanism is set up so they'll survive long term, and they also can multiply. They can basically, the inflammatory system can secrete what are called cytokines. And cytokines are kind of like, again, with our garden analogy, are kind of like fertilizer to make things grow faster and multiply faster. And this is a process that's important to try to get a quick response. So an example would be if you have say a terrorist attack in New York City, you send in your special forces, and they can quickly make many of themselves. So you might start off with 10 of them. Now you got 100 of them. Now you got 1,000 warriors to be able to fight. But you don't want them to be there forever. You want them to calm down, and they can go away by removing these stimulants over time. So this is, again, a picture, an example of how these, what are called cytotoxic T cells, which are these cells that have been activated to attack, can actually identify a tumor. And this is a electron microscope photograph of a melanoma tumor that's been invaded by what's called a cytotoxic T cell, and that's abbreviated as CTL. And you can see here on the left side of that cell, this little lump, and that's the T cell actually coming in and trying to attack the melanoma. And so our immune system is able to find tumors, but these tumors are smart and they can try to hide and block their ability to see. But melanoma is a classic cancer people can get, and we've known for decades that occasionally these tumors will automatically just go away without any therapy from the doctor. And that's because our immune system sees it and tries to attack it and kill it. There's some other things I'm just going to briefly talk about is we have mechanisms to get our T cells to activate better, and that's called the CD3 signaling domain. And there's been, again, decades of research to understand this process, the genetics behind it. And because we now understand this and all the research has been done, we're able to take this information, just like we're programming a computer, copy it, and insert it into cells to make them work the way we want to. Now, there's another part of the immune system called the Bcells, and I'm not going to talk about those today, but their job is to make antibodies. And antibodies are another thing you may be aware of that are designed to attack a tumor or to attack a virus infection or bacteria. And I like to think of antibodies like Tomahawk cruise missiles that the military uses. They're pre-programmed, and you push a button and they will only go to one target. But I'm not going to focus very much on antibodies today. So why is it important that we understand T cells and also how tumors work? Well, T cells, in theory, can eliminate a cancer. It's shown here again, this cartoon diagram. But cancer cells have the ability to actually to hide from our immune system. And there are on-off switches that T cells need to be able to attack. And cancer cells literally can turn a light switch off so the T cell can't see it. And these are called checkpoint inhibitors. And one of them is called PDL1. There's one called CTLA4, and there are other switches that cancer cells can use to turn off the immune system so they can hide. And now that we understand those things better, we can now come up with strategies to get our immune system to attack tumors more efficiently. So I'm going to skip a little bit here and talk about how this fits in to what we're currently doing. So about 30-something years ago, I was in a program in Baltimore where we were designing what was called allogeneic hematopoietic stem cell transplant therapy to cure people with leukemias and blood cancers. This is a very complicated therapy, but essentially back to our garden analogy, it's like we have weeds in a garden, which could be lymphoma or leukemia, and you have to use a very strong weed killer like Spectricide that you might get at Home Depot, but it will kill not only the weeds, it will kill all the plants in the garden. And we had to go back to a donor, say a brother or sister, who had a similar immune system code and transplant these patients or grow back a new immune system and grow back a new blood system so they could survive. When this therapy was pioneered in the 1980s, we thought the weed killer was what was important, this very intense chemotherapy or radiation we use to destroy the leukemia or the lymphoma. And this is a therapy, again, we started back kind of late 70s, early 80s, and by the 90s, it became standard of care if you had these very bad risk illnesses, if your disease, for example, relapsed, or we knew you weren't going to do well. Well, we started looking at this closer in around 1990 or so to understand more about what was going on with these patients. We had transplanted a lot of patients to use a donor to get seeds, these what are called the hematopoietic stem cells, these magic bone marrow cells that can make all the blood for us. We often use identical twins. And identical twins were easier because we didn't have all the complications that went along with the side effects of the transplant. And in the short term, they did better. But as you can see here, what we saw was over time, the patients that had used an identical twin to donate for them had a higher relapse rate. 50-60% of those patients' tumors would come back after a few years. Whereas if we use what's called a match-related donor that was a brother or sister that was not an identical twin, they had a much lower relapse risk. And then finally, if we saw what's called graft versus host disease, and a graft is the donor cells attacking the host. So we get what's an inflammatory response. It looks like often like a sunburn. If that occurred, we even saw lower relapse risk, such that those patients ultimately were the ones that did the best. And what that told us was that the donor T cells were attacking the tumor and giving you lifelong immunity. And that concept became the mantra 30 years ago, that we wanted these donor T cells to attack and clear leukemia, lymphoma. And the reason these transplants really work so well was because of the T cells from the donor. It wasn't quite as important how we got those T cells into the patient, how intensely we did, but we just wanted those T cells to attack. And if they did that, these patients had a much better chance of living long-term and being cured of their disease. And so that is a critical concept that has been a foundation ever since about what's called immune therapy. So this concept was subsequently used where we took patients with leukemias and we just took T cells from a donor and infused it into them. We didn't have to treat them with any intense therapy. And this slide shows us what's a disease called CML. CML is called chronic myelogenous leukemia. And if we gave those T cells to a patient, the CML would disappear, and about 70–80% of those patients would be cured. Now, that didn't work as well for other diseases like ALL, which is acute lymphoblastic leukemia, and not as well for other myeloid leukemias. But it also did work pretty well for a lot of lymphoma patients. And the reason it didn't work well in ALL wasn't because we didn't give them T cells that didn't work properly. It was because the ALL cells were smart and could hide from them. So this led concurrently with 30–40 years of research in how can we design T cells to work more effectively? How can we teach our T cells to attack tumors better? So it's just like taking them to school and saying, we're going to train you just like we train the Marines. We're going to teach you and train you. So it's what we do is we're programming them. Just like we had a robot and we're going to insert a new program into them to teach them how to be more efficient at eradicating something. So I'm going to talk to you today about CAR T cells and CAR T cells, the mechanism of action. What is a CAR? How do we define that? How did that term come? And how these treatments are currently being used. So CAR T cells are essentially the following. We take a patient and we take some of their immune cells from them. These are their white blood cells. And that's a technique called leukopheresis. And that's something we just do as an outpatient. It takes maybe 60 minutes to take somebody to do this. They just sit in a nice chair. We attach them to a machine, the same machine people donate blood at the Red Cross on. And then we take those cells and we take them to a laboratory. We insert a gene into them and we reprogram them. And then we grow them. It takes about 3 or 4 weeks. And we do quality testing. And then we give them back to the patient after they're given some chemotherapy, kind of like if they're going to go through a stem cell transplant. And then we have to support them to go through that therapy. And what happens is the following. We take the T cell that we took. This cartoon again shows on the left a T cell and on the right a tumor cell. And we take that T cell, we take it to a laboratory, and we have hundreds of thousands of these cells that we collected from the patient. And we insert a virus that carries a code. And this is just a little vehicle to insert DNA to reprogram it. Not any different if I came to your home and I sat down at your computer and I reprogrammed your computer. And that's really what we're trying to do, is change the code of the T cell so it will work more efficiently. And we start expressing what are called CARs. These are called chimeric antigen receptors. As you can see here, these blue and orange receptors, they're called, they are sticking outside of this purple cell. These are antibodies. And antibodies are my key. They're very specific, and we've designed them to fit into a special lock. And the lock we're after is lymphoma or leukemic cells that are called CD19. And that's like it wouldn't be different than I gave you a key that could only fit into one lock. Well, we have the key to fit into a leukemia or lymphoma cell. And we put those around the T cell. And that's kind of like Velcro. If you have, remember those games with kids play, if you have a Velcro ball and you throw it up against a felt pad, it sticks to it. And this will stick to a leukemia or lymphoma cell when it attracts to it. And so we expand these, and the CAR T cell is now able to recognize the tumor, as shown here in this diagram. and it attaches to it. And once it attaches, it turns on the light switch. And that light switch now allows that T cell to activate and make hundreds and hundreds, if not thousands of itself. And these will now multiply, and they will release little, what are called granulozymes, which are like little grenades to attack the tumor cell and kill it. And we call that apoptosis. And that's what CAR T cell therapy does. When this occurs, this creates a tremendous inflammatory response. It'd be like getting a really bad case of the flu. You get high fevers, you start aching all over where you don't feel well, you may get confused because of this high fever and inflammation. But once the tumor goes away, all those symptoms generally regress. And what's different about CAR T cell therapy is if this therapy is effective, within a few weeks, all the leukemia and all the lymphoma will be gone, which is very different than how chemotherapy treatments work. So briefly, I'm going to just talk about the chimeric antigen receptors, just the design of these cells. We have on the outside, again, this cartoon, the orange area, this is called the antigen binding domain, which is really the antibody surface. It's like the light chain of an antibody. And it's the key piece to be able to see that tumor. And it's attached to basically a hinge. It kind of swings on the outside of the cell. And on the inside, it's basically like an electric cord. And when it gets triggered, it's like a mouse trap, and it triggers it and causes the cell to activate and become a killer, to release these toxins to kill the tumor cell, but also to make these cells divide and multiply. So they start multiplying thousands of times over. I don't know if those of you are old enough to remember this book by Kurt Vonnegut called The Andromeda Strain, where when this virus infected people, just multiplied millions of times over. That's essentially what this does. It causes your T cells to multiply tens of thousands of times. So you create a whole army of these cells, and you become able now to clone these T cells for yourself to attack. For the purposes of this next data I'm going to show you, the key that we're after is called the CD19. The CD19 is a receptor on the outside of a lot of lymphoma cells and B cells. And we're able to identify that and generate a CAR T cell to attack that specific tumor. So this is an example of a true case of someone's CAR T cells surrounding a lymphoma cell or leukemic cell. And the cells that are in green and orange and blue are the CAR T cells. And the cell that's kind of that light green and the dark blue nucleus is the tumor cell or the lymphoma cell. And they're attacking and killing it. So back again to my early diagrams about the B cells. Well, B cells divide into different types of tumors, but B cells have different lifespan, and they can turn into acute lymphoblastic leukemia, they turn to lymphomas, they turn to MultiMyeloma. And by knowing that, we have a target that we can attack with a very similar CAR T cell. So if we can design a CAR T cell to kill leukemia, it's also going to likely kill most of what are called B-cell lymphomas. And we can modify it also to kill what's called MultiMyeloma. So what are the advantages of CAR T cell therapy? Well, you just need one infusion, at least in theory. They don't require you to have a donor. You don't necessarily need a brother or sister. You can use your own cells. So that's a huge advantage because we don't have all the side effects associated utilizing a donor that is similar to the therapy we pioneered 30 years ago. We can target our tumor markers, so we can design these to target, and it works very rapidly, and they can proliferate inside the patient, so we don't have to spend lots and lots of time and energy and expense making these outside the laboratory. And most importantly, we don't have this risk called graft versus host disease. We don't have to worry about these cells being different from the host. They're their own cells, so they're only going to attack the tumor and not attack things outside of that target. Now, the other thing these cells may be able to do is have memory. They can potentially live forever in someone once we design them. We don't really know yet if that's true for everyone, but they can give long immunity protection because they're your own immune cells. So the first therapy this was designed in is in children with acute lymphocytic leukemia. And this is pioneering work that was started about 15 to 20 years ago by groups at the University of Pennsylvania and also at Memorial Sloan Kettering and out in Seattle. And this is some data that I want to share with you about acute lymphoblastic leukemia in adults and in children. When we see people with this particular leukemia, usually the therapy is we treat them, and if they have standard or high-risk disease, we're going to frequently take them on to transplant therapy. And the reason we do that is because once they relapse, they generally don't do very well. Almost all those patients will eventually die from their leukemia once it recurs. And this is an example showing that less than 25% of patients are going to live long-term. These are what are called survival curves. And at the top, it shows 100% survival. And at the bottom of that graph, it's 0. As you can see, all these curves are working their way down to less than 20-25% survival. So this is the baseline expectation. And these are, in my view, even favorable because most of these patients, this includes all patients, but once you've relapsed 2, 3, 4 times, it's very rare for us to cure that patient. Well, this is an example of CAR T-cell therapy. This is a trial that was originally done in young children and young adults with multiple recurrences of acute lymphoblastic leukemia. A lot of them, I think about half these patients had relapse even after a transplant. And what was seen was that within 30 days, over half those patients had entered into complete remission after getting CAR T-cell therapy. And as we followed them over a year or longer, a lot of those patients remained in remission, such that at least half of them were still alive and free of disease at 1 year. And so this was done in multiple, looked at different formulations of this and showed that these response rates were very high, 60, 70, 80, even up to 90% complete response rates. And this is pretty impressive. We don't have any chemotherapy drug that can do this, that can get patients at this high response rate once they've had multiple relapses. Now, these patients did get a lot of side effects from this therapy that I could talk about more in the Q&A session. This is called cytokine release syndrome. And these are the little warriors releasing their basically cytokines, which are like little grenades to try to kill the leukemic cells. But these do have side effects on patients. And the primary definition of cytokine release syndrome is high fever, blood pressure can fall, people may have difficulty breathing, they can get disoriented or confused. And this occurred in most of the patients, but it was generally manageable, and there are antidotes to manage this and generally regress within a week or 2. So in conclusion of this trial, this was a worldwide effort. They saw durable complete remissions, durable meaning now over several years. Many of these children and young adults are still alive and without any evidence of relapse of their disease. And this was the first therapy of CAR T approved in August of 2017. So based on this information, we started looking at what's called Bcell NonHodgkins lymphoma. And the Bcell NonHodgkin lymphoma have the same target that these children's ALL have, which is called the CD19. So we didn't have to really modify these CAR Ts. We could take the same therapy and now look at it non-Hodgkin's lymphoma. And again, we looked at patients with poor risk lymphoma that had multiple recurrences. We had pioneered therapies years ago looking at transplant therapy for people with lymphoma once they relapse, and showed that you could help about half those patients with a therapy called autologous stem cell transplant. But unfortunately, a lot of our patients either can't get that transplant because their disease is so resistant, or they relapse after transplant. So this was a study to look at, could CAR T cells help that group of patients? And here on the right is what happens in people who multiple relapses. Again, similar to the children with ALL, the vast majority of these patients, over 80% of them, will die within a year or two once they have multiple recurrences. So this was a study called the ZUMA 1 phase 2 trial that was using CAR T. And this is again a graph showing this. In blue is the CAR T cell therapy called the ZUMA. And on the below that's the red line, and that's what we would predict would happen to these patients if they did not get the CAR T. And you can see at the top says 100, that means 100% survival. At the bottom, 0, and then the x-axis along the line 0 through 16 are months of time. And over time, what we saw is over 60, 70, 80% of those patients were still alive at 6 months and at a year, compared to what we would have predicted. And many of these complete remissions are durable. And what we've observed was if patients within 30 days went into complete remission, they got scans showing the tumor had completely melted away, those patients overall generally did incredibly well. This is another example just showing duration of response, and the green line is those patients called CR. That means at 30 days after the CAR T cell therapy, they got scanned, it was all gone. Those patients did incredibly well, and the majority of them have remained in complete remission now with several years of follow-up. So what have we learned from this? Well, what we showed was that compared to historical experience, using CAR T cells was very effective and better than any other therapy we could offer them if they had failed transplant therapy. We were able to generally 99% of the time produce CAR T cells within about 3 weeks after we collected from the patient. And we saw that at least half those patients, if not more, went into complete remission by day 30 after the treatment. Now, we did see, again, a lot of side effects from this therapy. It's not an easy therapy, and it has to be done in the hospital. The majority of patients get what's called cytokine release syndrome, where they get high fevers and they can get pretty sick from it. And about a quarter of those patients get what are called neurologic side effects, which means they can become confused, disoriented. A lot of them look like they're having a stroke, but those things are generally reversible over time. So this has now led to other products now being developed. Multiple pharmaceutical companies have come out with their products, both in lymphoma and leukemia, that have been approved. So we're not just have one particular CAR T treatment. Now we have quite several of them for lymphoma, and we've also now pioneered these in myeloma. And MultiMyeloma has a slightly different target that we're looking at called BCMA. The CD19 receptor is lost in myeloma cells or plasma cells. That goes away. So we had to look for a different target. This is called the B-cell maturation antigen, and that is expressed on the majority of patients with multiple myeloma. So a CAR T cell was designed specifically for myeloma, and this was also shown to be effective. Over 90% of patients responded to these CAR T cells, and these are patients that had failed on average about 6-7 different chemotherapy treatments over years of therapy, and almost all of them had failed transplant therapy. And about half of them went into a complete remission within about 6 months. So at the present time, we have 6 products that are now FDA approved approved by the FDA for Bcell ALL and various lymphomas, including diffuse large B-cell lymphoma, mantle cell lymphoma, follicular lymphoma, and now multiple myeloma. And we also expect some neuro products that we're currently testing to also be approved for myeloma, and there are trials ongoing now for melanoma and cervical cancer. This is just some of the research we're currently doing. We're looking at this in adults now with acute lymphoblastic leukemia, because right now it's only approved in children, very young adults. So we have 2 trials we're doing in that. We're looking at using CAR T-cell therapy earlier for patients with high-risk disease that we know are not going to do well or have early relapse, and we're trying to decide, should we take them to transplant or should we just take them on to CAR T? We're looking at this in chronic lymphocytic leukemia, as well as other newer products in myeloma and mantle cell. What is important for everyone to understand, this is just the first generation. Just like Apple comes out with their iPhone versions, every few years they're coming out with a new iPhone. We're anticipating that these CAR T cells are going to come out with the next generation, the 3rd generation, the 4th generation, because we're learning why they're not working in the patients where it fails. And we're designing new versions of these to get around the smartness of cancer cells. They're very smart. They figure out how to evade things. And as we understand cancer cells better, we're now to redesign these and reprogram these cells to be more effective. There are other trials now being looking at in acute myelogenous leukemia, Hodgkin's lymphoma, myelodysplastic syndrome, and there are even studies now looking at certain viruses to go after. So this is a very exciting area. There's a lot of research ongoing, and I think over the next 10 years, we're going to see a lot of advances in this field. So I'm going to stop there, and again, thank everyone for letting me have a chance to present this to you today.
Thank you, Dr. Holland. I have a list of questions that have been submitted, and a lot of this you have addressed, but one of them was, you mentioned that hospitalization was required for this. What is the typical duration that most patients can anticipate staying?
Each of the different CAR T-cell products and the disease is a little different, but I think on average, patients are in the hospital for about a week, but they may be in the hospital much longer. There are some patients that only have to be in the hospital for a few days, but the typical patients in the hospital for about a week. And the reason is we expect them to start getting what's called cytokine release syndrome symptoms within the first several days of getting the CAR T cells. And we want to be able to observe them. And if they don't have problems, then we'll let them go out of the hospital. But if they do, we want to keep them in the hospital and manage those side effects.
That was one of the questions as well, was one of the barriers to the CAR T cell therapy has been the CRS, or the cytokine release syndrome, and the neurotoxicity. And I suppose you do have a mechanism in place to monitor these patients. I know they're doing their vitals, as well as, do you have a mechanism for evaluating for the neurotoxicity?
Yes, so when a patient goes through CAR T cell therapy, they have to be followed for 60 days.
Okay.
Of which 30 days is usually by the center, so the CAR T cell center, and then the next 30 days usually back by their oncologist. Usually we're seeing neurologic side effects within the first 30 days, and that can be confusion, it can sometimes seizure, other serious neurologic side effects like stroke-like symptoms. So if those things occur, obviously the patient's in the hospital being managed. We're learning more and more, even over the last year, how to better manage these side effects. We have antidotes to try to calm the immune system down that's causing this problem. We oftentimes use steroids to help reverse it. But there are patients that can have serious side effects and have to stay in the hospital a lot longer. So the FDA requires all patients to be monitored for 60 days, and they won't let patients drive or operate it. Like you can't go fly an airplane or do anything like that for a minimum of 60 days. But if after that you're doing well, which we'd expect most patients are, then you can resume a normal life activity.
Okay. You mentioned steroids. I believe steroids are used predominantly for the neurotoxicity as well. And then
yes,
IL-6 inhibitors are also used for the CRS syndrome. Is that correct?
Yes, there's an antidote to use, a drug called tocilizumab, which is an inhibitor of what's called an IL-6 cytokine. And when we give that, it causes the fevers to go away and the inflammation subsides. But it doesn't seem to have any adverse impact on the CAR T cells themselves in terms of being able to attack the tumor.
Correct. It's interesting. That was also recently used for a lot of the patients with COVID cytokine release syndrome as well. So a lot of patients may be familiar with that drug. I have another question that's been participant. It says that, how do I know if I have enough white blood cells to undergo CAR T-cell therapy? And how long does it take to retrieve enough for this therapy?
So that's a great question. So for patients who are potential candidates for CAR T-cell, you're seen at a treatment center. Lab work is done, including a blood count, and we just look at your blood smear. And we can look for what are called lymphocytes, and can even drill down closer and see how many T cells you have. You need a minimum number of these cells to be able to collect, but it's not you don't need a lot of them because pheresis is very efficient. And as long as you have a minimum threshold, then we can go forward and collect these cells. And the process, as I mentioned earlier, is just sitting down in a nice lounge chair and either having an IV placed or a catheter inserted. It takes about 60 minutes to be connected to what's called a pheresis machine that very gently skims out the T cells through a centrifuge process, just like if you were donating blood at the Red Cross. And you can watch a movie, and then when you're done, you go home, and then those are taken. We count the number of T cells that were obtained, and we ship them off to a special laboratory where they will be processed. And it takes about 3 weeks currently to complete. And then the cells can either be frozen or shipped back fresh.
Okay. Another participant question is, this patient completed treatment for relapsed low-grade follicular lymphoma. Should they expect hope for this treatment for potential next relapse?
Well, for follicular lymphoma, it's a good question. There are many therapies for follicular lymphoma currently. A lot of those can be done as an outpatient and do not have a lot of side effects. So those tend to be the first line treatments currently. Transplant therapy is an option for patients. And then finally, CAR T-cell therapy recently got approved. And that's primarily approved for patients who've had multiple relapses. And I think it comes down to speaking with your oncologist, understanding more about where that treatment may or may not fit in. Because CAR T-cell therapy does have potential serious side effects, it's not used as upfront therapy or even after maybe 1 or 2 relapses. It has its role, but it needs to be thoughtfully looked at, based on a given patient's condition.
And that was one of the other questions for someone who has, where's the role? Because they're wondering, will this ever be, or do you think this will be considered upfront in the future? Or do you think it requires more investigation?
That's a great question as well. I think for now, that's going to require a lot more investigation because it does have a lot of side effects. It's also a very expensive therapy currently. So because many patients with follicular non-Hodgkin lymphoma will do well over a long period of time, I don't think those are the patients we would offer as upfront therapy. There is a subgroup of patients we can predict are not going to do well with either what's called CLL or certain follicular lymphoma group of patients. And that may be a population we would offer this treatment, maybe not necessarily as upfront therapy, but as second line therapy when their disease recurs.
Okay. With regards to the cost, are you having difficulty with insurance companies covering this procedure? Are there any programs out there to assist patients?
So another great question. All the major commercial insurance companies are paying for the therapy. We've not had any of the insurance companies refuse to cover the cost. It is very expensive. The pharmaceutical company that produces the CAR T cells for us charge about $400,000 to $500,000 just for the product. But the commercial payers have agreed to pay for that. Medicare, until recently, was not covering the cost, but Medicare has now come up with better ways to compensate the hospitals for the expense. It's not quite complete, but it's enough that centers such as Northside and many other centers in the country are now agreeing to take care of Medicare patients. For patients that do not have insurance for various reasons, there is financial assistance programs that companies such as, say, Novartis are doing that produce the CAR Ts to actually, they'll produce it without charge to that patient. And then there are other charity efforts to otherwise provide the support for those patients. So I think currently that may be more of a challenge, but we certainly have the ability pretty much to take care of most of our patients at present.
Okay, I have another participant question. What indicators will my physician consider when suggesting transplant versus CAR T therapy? It doesn't say which particular disease state, so I'm assuming for probably the diffuse large B cells and the folliculars and the...
So currently, autologous stem cell, for people with recurrent, say, diffuse large B-cell lymphoma that's responding to treatment, autologous stem cell transplant therapy, it used to be called autologous bone marrow transplant therapy, is the standard of care. That's the gold standard that's been in place now for 30 plus years. CAR T-cell therapy is not recommended for that group of patients. It's only recommended if you've had multiple relapses or you've relapsed, for example, after an autologous transplant. Now, those recommendations may change over time, but that's the current standard. And I expect we'll see that may change over the next 3 to 5 years as we get more information. We just finished a trial comparing CAR T-cell therapy to upfront autologous stem cell transplant. So we just don't have that data yet. We'll know in about another year or two if CAR T-cell has a role as part of upfront therapy for either high-risk patients or patients that relapse.
And you touched on this with regards to the duration, the T cells, the engineered T cells, but do we anticipate that they're going to remain lifelong in your body, and will they recognize if there's a recurrence again of the lymphoma?
So we don't know the answer to that. What's been observed is some patients a year or two later, we can still find the CAR T cells. Some patients after a few months, the CAR T cells are gone. And then there are patients in between. The FDA has mandated that all patients have to be followed for 15 years just to make sure there are no problems having these CAR T cells still potentially in you. And many patients are being asked to volunteer to let us continue to test their blood looking for these CAR T cells. One of the main side effects of CAR T cell for ALL and B-cell lymphoma is if they do persist, they can, an innocent bystander effect of this is they will attack the B cells of that patient such that that patient may not be able to make antibodies. And that means they're more susceptible to infection. So they have to be monitored. And if your antibody levels stay very low, it's likely these CAR T cells are still persisting in those patients.
And that was one of the other questions, is that are you more likely to be vulnerable to infections? And especially in this time with the pandemic, particularly the coronavirus. That was one of the other questions.
So in the short term, yes, you're more vulnerable to infections. Short term meaning within the first 3 to 6 months. Long term, we're not necessarily observing that, but for patients who have low antibody levels, we know they are at higher risk for getting certain specific infections. Those are primarily bacterial infections, but we certainly would be worried about them also, say, if they were exposed to COVID and want to give them some additional antibody protection.
Okay. Are there any medications to avoid prior to beginning CAR T therapy, or ones that would interfere with the collection?
So there's a list of things that we want to avoid, and we don't want patients actively on steroid therapy and certain chemotherapy agents that can kill T cells. So steroids can suppress your T cells. So we don't want to reduce our T cells in those patients. So we have to hold those medications for a few weeks. And that can be a problem because the lymphoma could grow back quickly. So it can make it very difficult. So we have to watch those patients very closely with their oncologists to make sure that they don't fall through the gap there, that we know that we're releasing the reins a little bit on lymphoma. It's going to start growing, but we have to wait to get those T cells. And once we get the T cells, we can then treat that patient, which is called bridging therapy, to keep their lymphoma under control while we're waiting to proceed forward with the CAR T-cell treatment in about 3 to 4 weeks.
Okay. And on average, how often do you follow up with the patients once they've recovered from their CAR T therapy?
So briefly, we see everyone for the first 30 days. If they are still having side effects, they continue under our management. If they are not, we let them go back to their medical oncologist and ask their medical oncologist to follow them. Usually at that point, they may be seen maybe once a week initially, and then maybe every other week, and then eventually maybe every month. And then we'll see them at 100 days, 6 months, so frequently at 9 months, a year and a half, 2 and 3 years.
Okay.
In between those, their medical oncologist is going to continue to monitor them probably every 3 months for the first few years.
So similar to transplant patients.
Yes.
Let's see. Let me see if we have any more questions. I think that's covered all of our questions for today. I don't see any further. Katie?
Well, thank you, Dr. Miller, for letting me present today.
Oh, no, thank you. Thank you for including me. I've enjoyed this.
Yeah, thank you both. And thank you everyone for entering in such good questions. We're getting a lot of positive feedback in the chat box. So thank you, everyone. So as we wrap up, I do want to invite everyone again to visit Cancer Support Community Atlanta's website. That's cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. And next week, you should be able to find a recording of today's program if you'd like to share it with anyone. So before we go, I want to throw it out to you, Dr. Holland and Dr. Miller, for any kind of final thoughts. Dr. Miller, I'll start with you.
The only other question was that, and we discussed, lymphomas, ALLs, and myelomas. Any other disease processes that you see in the future that could be targeted for CAR T therapy?
I think that any tumor that has a marker on it that is not shared by other important tissues of the body, so that they create a marker that we can attack, would be potentially susceptible to CAR T-cell treatment. So as I mentioned earlier, melanoma is being looked at, cervical cancer. This is being looked at in brain tumor, variety of different brain tumors and other solid organs. The question really is, will those be amenable to CAR T? Because it's very different than leukemic cells, which are individual cells that these CAR T cells can surround. It's like a bunch of a swarm of bees surrounding something. Whereas if it's a solid tumor and it's all compact, it may be much harder for these CAR T cells to get in and to attack and eradicate the disease. So there's a lot of study and research to be done to determine if this is going to have a significant role outside of, say, what we call the blood cancers like leukemia, lymphoma, myeloma.
Okay, thank you.
All right, great. Well, thank you again, everyone, for coming. For additional information on Dr. Holland, you can visit the Blood and Marrow Transplant Cooper, Georgia at their website. And again, for additional information on Dr. Miller, you can visit the Suburban Hematology and Oncology Associates and their website is GwinnettCancerCare.com. So thank you guys both for coming, and we hope to see you again soon. Take care, everyone.
Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.